All right. So I have Dr. Melanie Altas with me today to discuss a topic that I've actually had on my hit list for quite a while because I think this is something hardly anyone has heard of, Lichens sclerosis. And I, as a physiotherapist, I always like to set the stage as to kind of why am I talking about this? And I always picture that, the clients that come in that have symptoms of, maybe pain with intercourse or leaking or vulvar pain or something has brought them to a physiotherapist. And just like if you had shoulder pain, I would look at your shoulder. When I do an exam, or when we do an exam, the outside of your pelvic floor is partially comprised of your vulva and your vulvar tissues. And so I look at it from the outside, and sometimes I see signs that I think this looks like lichen sclerosis. But as a physiotherapist, it's not within my scope of practice to diagnose that or to be able to provide treatment options. But when I ask questions around, have you heard of lichen sclerosis? And they say, what's that? Or what's going on? I would love to be able to recommend something like this podcast episode so that they can go home and listen to some information before they make their next steps. So thank you so much for being here, Melanie. I heard about you actually and the BC Center for Vulvar Health on Instagram. And somehow maybe we were following someone similar. I'm not exactly sure, but I've noticed that your platform is talking a lot about lichen sclerosis, and you're obviously in the same province as me. So, I reached out looking to see if you would talk to me about lichen sclerosis, and I appreciate that you said yes.
Thank you, Melissa. I'm really happy to connect with you and to have a conversation about lichen sclerosis. And I would certainly endorse everything that you said about the importance of education. So yeah, we did connect on Instagram. So we had started our platform last September, and our Instagram account is hello.vulva, and we're really happy with how it's going so far. And our goal with this account is to normalize conversations about vulva vaginal health and sexual pleasure. So I'm so glad that you connected with us and reached out.
Will you tell everybody that's listening a little bit about you? Who are you? Where are you located? And what brings you to this area of practice?
Sure. So I'm a gynecologist and currently the director of the BC Center for Vulvar Health, which is based in Vancouver, BC. So we see basically all things vulva. So we have a vulvar skin condition clinic, we have a vulvar pain clinic, we have a precancerous and vulvar cancer clinic. And we also see people who have gone through cancer treatment and have some concerns about vulva vaginal health, sexual pleasure, and frequently experience menopausal symptoms. So my journey, though, to where I am right now was not really straightforward. So I've been in practice as a gynecologist for 15 years, and I started out as a community gynecologist, where eventually over time I developed a specialized practice in vulva vaginal conditions and sexual medicine. And this wasn't exactly where I thought it would end up, but over time, as I started seeing people in my office who were really suffering from vulvar skin conditions, I realized it was a really underserviced area, and it was not something that we were taught very well in medical school, and so it was something I just decided to learn about on my own. And once I started learning about it by attending conferences and courses, it became actually very manageable to navigate these conditions with patients, and became so rewarding as well, because patients truly suffer for a long time before they find a diagnosis and treatment. So I really organically just found my way here, and then eventually over time I ended up now full time at Vancouver Coastal Health at the BC Center for Vulvar Health, and this is what I do now, Monday to Friday.
That's great. And I think that that's the benefit of working in some of these larger centers is you have that option. We definitely don't have anything like that here where I live in Kelowna. But I think that conversations like this, as you mentioned, are just so important to be had and to normalize. I can just picture the relief coming off of some people's shoulders that are listening to just at least help direct their care and what questions they need to start asking their care provider, because just because we don't have some of these bigger centers doesn't mean there isn't still help, right? Just kind of knowing what you're going in looking for. So, can we start, because obviously we want to focus like very specifically on lichen sclerosis today. And I wonder if you can start by just describing what is lichen sclerosis, because as I mentioned, most people have never even heard the term, but it comes with such, well, I'll be honest with you. I struggle with when I look at a vulva that I think might have someone that might have lichen sclerosis. Everybody wants to know, oh, well, what do you see? And sometimes I struggle with, you know, I don't want to scare them saying like, the tissues look a little bit more white or some of the tissues look a bit fused. I wonder if you could start before we get into the details of just explaining what it is. What is lichen sclerosis?
Absolutely. So this is actually the most common skin condition that we see in our clinic. So it's a chronic inflammatory skin condition affecting the genitals. And by inflammatory, sometimes people have a hard time, like, well, what does that mean? And if you think about one of the more common skin conditions that people know about, like eczema or psoriasis, those are also inflammatory skin conditions.
Mm. And what kind of things would you say people are normally complaining of? So obviously, they might have not looked at their vulva yet. So if we kind of don't think yet of what it looks like, what symptoms are people describing?
Mhm. The most common symptom that people will have is itch, and it may start off being a mild itch, but can actually progress to being moderate to severe. So this would be itch of the vulva or the external genitalia. There are some people who will also experience a burning pain. And another common symptom that we see is people who have pain with insertional intercourse and may even have a tearing sensation.
But we know this is not contagious, correct? This is not something that you
Mm.
can spread between people.
Absolutely. And that's something, a common fear that people will have is people will worry, is it a sexually transmitted infection? Is it infectious? And those are absolutely not true. So I think that's a really great fear to kind of get out of the way at the beginning of the podcast for sure.
And so what if, okay, so someone's kind of experiencing maybe some itch, some burning, maybe pain with any type of insertion. What if they were to look at their own vulva? So I think them looking at their own vulva, or maybe someone comes in to see you and you're doing a vulvar exam, what kinds of things might you see?
And this is something that I would definitely advocate for is doing periodic vulva checks, even for people who don't have symptoms, just to become familiar with what does my vulva look like? What do the folds look like? What does the color look like? What's the texture like? And then if you do start to experience symptoms like the itch or the burning, and you look yourself at the vulva, some of the things that you may see are a paleness, a whiteness to the skin, or a thinning of the skin. And the classic distribution for lichen sclerosis is what we call an hourglass or a figure of eight. So around the labia and the vestibule, so the opening of the vagina, to the perineum, which is the skin between the vaginal opening and the anus, as well as around the anal or perianal area. And sometimes people may actually see a redness to the skin as well, particularly if it's severe. People may notice cracking in the skin or tears in the skin. Sometimes they may notice erosions. And with lichen sclerosis, we'll sometimes see changes in the normal anatomy. So we may see some flattening of the labia minora or the smaller lips. We may start to see the folds between the smaller lips and the larger lips kind of resorb. We may start to see flattening of the clitoral hood, and in some cases it may even cover the clitoris, so you can't see the glands of the clitoris. And this is called clitoral phimosis.
Mhm. And what do you do specifically to diagnosis? Is it simply kind of by their symptoms and by the appearance, or do you take any type of biopsy or anything like that?
Mhm. Yeah, so and actually just one more thing that I did want to say around the signs and symptoms is that sometimes people will be asymptomatic, meaning they have no symptoms. So there are some people where they may just be going to see their physician for their regular pap test, and their physician may notice some changes in the skin. That's not as frequent, but it is something we see where someone may not be experiencing itch or burning. So to make a diagnosis, particularly for clinicians who are experienced with vulvar skin conditions, they can most frequently make that diagnosis clinically. So just listening to the symptoms and doing an exam of the skin and seeing those changes that I had mentioned. There are times though where a biopsy may be indicated, and reasons for a vulvar biopsy would be if you're not sure that it's lichen sclerosis, if there may be another skin condition there, or if you've started a treatment and someone's not responding to the treatment in the way that you expect, then I would certainly advocate for a biopsy in that situation.
Melanie, if they're starting to have changes around the clitoris and the clitoral hood, would some of these people also experience a change in arousal? Does it affect that as well?
That is a great question, and a significant concern that people have as they start to notice the changes. And basically, the bottom line is that it's not predictable. So there may be some people who experience a decrease in arousal, a decrease in orgasm, a change in sensation. But there are also many people who don't experience that. I think if you're aware of the anatomy of the clitoris, there's so much more to the clitoris than most people know. So many people think of the clitoris as just what we call the glands of the clitoris, where it's just that small, maybe half a centimeter area that's exposed. But the clitoris actually goes quite far back into the vulva, and there's the bulbs of the clitoris which come down around the vulvar vestibule. So because of the extensive anatomy of the clitoris, there are many people who don't experience changes in arousal and orgasm.
You also mentioned, so obviously some of the implications would be just the irritable sensations, itch, burning, feels frail, maybe getting a little bit of tearing, sexual function, what might affect whether it be arousal or pain with any type of penetration. But I can imagine too, well, I see this, in when I kind of ask questions initially around, have you heard of lichen sclerosis, or are you managing lichen sclerosis right now? Right away there's this what's wrong with me, or am I not normal? What's wrong with my anatomy? And I think you touch on how different everybody's anatomy is that it's hard to say yours is perfect because everybody's vulva and vagina is so unique. But I think that's one implication, is that people start to fear that they're abnormal. And because I think, because our anatomy kind of lives inside as a female, we don't look at it very often, do we?
Mhm. Definitely, yeah, Melissa. I think you've touched on so many things there, particularly that emotional layer to a possible or confirmed diagnosis of lichen sclerosis. There's a lot of um, emotional aspects that that go along with that, or any concerns of changes in the anatomy, or this kind of quote unquote, am I normal? And I'm sure with your appointments being much longer than physicians, that's something that that you probably are able to kind of peel back those layers a little bit more than physicians who have 10-minute appointments with patients. But we frequently see that kind of shame. We see grief. We see a lot of anger and frustration. We will see a lot of worrying, worrying as well. And those are things that we're not great at navigating within medicine. And I'd be really curious to hear your perspective on that with your lovely longer appointments.
Well, it's funny because I think of, some of these people are coming in because of something that's already affecting their life. I'm not able to be intimate. Sometimes the intimacy discomfort is also tied to them being a postpartum woman, but they're coming in and they're linking it to their pelvic floor, whether it be their midwife or their doula or their friend has said, you know what, you should see a pelvic floor physiotherapist. So it's already affecting their life. But then when I do an exam and I see that maybe they're also, yes, there's a pelvic floor component because those muscles are obviously feeling tense. However, I wonder if they're tense because your skin is irritated, right? And there will be that postpartum component, the sleep deprivation, the nervousness about having intercourse, the resulting pelvic floor muscle tension. But another layer is probably this skin discomfort or this tissue discomfort. And now I need to bring something else up to them, right? And something else to put on their plate that they have to worry about. That's not my intention, but I kind of know that's what's going to happen. And so I do find this is something, as a practitioner that I find it hard. I know that they're leaving the appointment having another added stress. And I really hope that this episode can help to not only shed some light on maybe why they're experiencing these symptoms and that they're not abnormal, that they're, our tissues and our body changes at different times in our life, but generally there's help out there, right? And there are so many layers to the onion. Yeah.
Absolutely, yes. And I would absolutely agree with you when you tie in that connection between the vulvar skin and the pelvic floor. And you and I know definitely there's an obvious connection there, but for many there's not. And I agree with you. We commonly will see people who have irritated or inflamed skin, and they may or may not be experiencing painful sex, or maybe pain with urination as the urine touches that skin, or pain with having a bowel movement. And what we would expect in response to that is a tightening or an increase in activity of the pelvic floor, which can certainly then exacerbate all of their other symptoms. Yeah.
So I'm curious to know then, because I have heard that we still don't know exactly why people end up with lichen sclerosis. Am I right?
Yes.
So if
Yes,
someone says to
absolutely.
you, someone asks you, why did I get this? What do you usually say?
Yeah. So I think what's really important in that situation is to address what may be their fears of what's causing that. So I may even start out by asking them, particularly, is there anything in particular you're worried about? And that may be where they bring up the sexually transmitted infections, or being any other type of infection. Or we'll sometimes have people will make like just really kind of associations that are absolutely not true. So I first want to know, is there anything they're worried about, and address that. And then you're right, we actually don't know what causes lichen sclerosis. And the best kind of theory out there right now is that it's autoimmune related, and that for some people it may be autoimmune related, for others it may not. There may be a genetic component as well. We will sometimes see it being a familial association, but that's not also not always the case. And what's likely coming into play is that it's individualized and it's likely multifactorial. And there are so many things about medicine that we actually don't know the answers to. So is it possible it's diet related or environment related? It may be, and we actually don't know. We don't know that answer.
We're always learning.
Yeah.
Would you say then, if you see someone that has lichen sclerosis, is one of your questions normally to ask if they have something else autoimmune? Do you find that quite often they have some other autoimmune issue going on?
Mhm.
Yeah.
No, actually, I think that's a great question. And it's something that we haven't actually looked at with our data or with our population. But no, it's
Mm.
not always the case. And certainly my feeling is that not even the majority of patients will have another autoimmune condition. And I would say as well that also the majority of our patients don't seem to have a familial connection to.
Hmm.
So it may just be an isolated autoimmune condition. And the other thing too that people will ask us when we do suggest it may be autoimmune, they'll ask about screening for other autoimmune conditions, and that's not something that we would routinely recommend.
Do you notice that it tends to, because they've linked quite a few things, autoimmune and stress, right? That stress can be a catalyst. Do some of these people tend to describe that there's another stressor going on in their life when their symptoms start or quote unquote flare?
Yes, definitely. So stress is actually a big trigger. Not so much maybe the initiation of the condition, but it's something that we do see related to flare up. So any type of stressful event in someone's life. And there are some people where this will be a stronger association than others, and where they'll have insight into maybe their anxiety, worrying, health anxiety around their lichen sclerosis flares. The other trigger that we'll see as well will be heat too.
Mm,
So there's some people where they'll notice their symptoms will flare a little bit more in the summertime.
interesting. Yeah, I can just picture, and that's the thing is I'm seeing more often what I think is lichens. Again, I can't diagnose it as a physio, but generally what I would do is I would say, this is one thing that this could be. Do you have a relationship with your family doctor? Often I'll write it down saying, ask your doctor about this, but I'm seeing it more. And I don't know though if that's just me assessing differently, or we are living in a stressful state right now in the last several years, and I just can't help but think, am I just looking for this more, or am I seeing it more? Again, you're at a center that draws people in for this, so sometimes it's hard to be able to say we are seeing more of this, because I think too, all of these platforms have the benefit of sharing knowledge, which how many people just weren't even noticing that they had this before. So I think it's hard obviously to comment on numbers, but I wonder if you have anything to say about that.
Yeah, I think that's a really a great question. So particularly with COVID being a big stressor, has that led to an increase in lichen sclerosis or flare-ups? And that's also something that we don't know yet. Possibly there have been people studying it during the last couple of years. And you're right, it's really hard for me to answer that, because with our clinics, which we run skin condition clinics Monday to Thursday, the vast majority of people that we see have lichen sclerosis. So my perception would be quite different. But you're right. There's also that added layer of education, and these type of platforms like podcasts and webinars and social media, where the word seems to be getting out a bit more, where people are gaining knowledge and becoming more empowered to advocate for themselves. And with lichen sclerosis, when you look back historically, many decades ago, it was thought to be mainly a postmenopausal um, condition. But we know now that it actually can affect, children, teens, right, reproductive age people, right through to postmenopause. And it's likely that the lichen sclerosis just wasn't getting diagnosed in premenopausal women. But as people become better advocates, as we improve medical education, that now they're more likely to get a diagnosis premenopausally. And we've seen so many women where they've been treated for recurrent yeast infections over and over and over again with like longstanding itch, and it ends up being that they actually have lichen sclerosis. It just took a long time for them to get a diagnosis.
That was something that I wanted to ask you because right around the time that this episode is airing, I'm also doing having a discussion with a urologist around GSM and just symptoms of menopause, and how sometimes we didn't talk about this in this episode, but it's coming to mind as you and I talk, that sometimes the appearance can kind of look the same as a vulva or vagina that's missing estrogen. So I wonder if you can talk a little bit about, because some people hear some of the same terms here, the paleness, the thinness. I wonder if there's a few hallmark differences that, because not only are there clients listening to this or people that just have vulvas in general, but there are other therapists and other people that do vulvar exams listening to this. And even though it's not in our scope to diagnose anything, I wonder if there's some differences that you could point out that people could kind of pay attention to.
Yeah, as someone goes through menopause and is losing their exposure to estrogen, it's estrogen is the hormone that keeps the tissue stretchy, pliable, elastic. So, as you lose estrogen, we frequently see that the vulvar tissue will become thinner, will become paler, and may also start to flatten as well. The one thing we wouldn't see with normal menopausal changes would be the clitoral phimosis. So that's the covering of where the clitoral hood covers the glands of the clitoris. What I recommend in that situation is to monitor the change over time. So with lichen sclerosis, we would expect there to be progression of the disease. And so this would be someone who's not symptomatic, because obviously if there's itch and all the other findings, and that would be consistent with lichen sclerosis and not the changes with menopause. But in someone who's asymptomatic, where they've identified, or the referring physician has identified, some possible signs of lichen sclerosis, we'll actually take a photo. And we're lucky in our clinic, we have the ability to take photos and keep them in patients' charts. Or if they don't, then when I was in the community, I would have people take a photo of the vulva, or I would take it for them, and they would just keep it on their phone, sort of in a hidden folder. And then we would have them come back in 6 months and we would do a comparison. And with menopause, you wouldn't expect a progression of those changes over time.
I wonder, before we kind of move on I want to talk a little bit more about things like what happens if this goes untreated. Let's talk first about treatment. So what does that look like? What's someone's option when they are suspected to have lichen sclerosis?
So this, we have a multifaceted approach to the treatment. And the first step is we really value the importance of education. So we have handouts about lichen sclerosis. We will provide education in the office about what the condition is, what the progression is, that this is a lifelong condition, which is very important. We also will talk about vulvar skincare. So with an inflammatory skin condition, it's really important to stay away from any irritants. So any of those fragranted products, all of those feminine hygiene products that are marketed extensively to us, just throw those all away. And we really advocate for just washing the skin with water or a very bland product, which we have listed on our handout on our website. We also recommend using a protectant barrier, so either a bland moisturizer or a barrier cream. The mainstay of treatment is topical steroid ointment. And for lichen sclerosis, we use either the super potent ointments like clobetasol or the potent ointments like mometasone. And we know people are always really afraid when we talk about using anything potent on the vulva. People get a little bit, oh, I don't know about that. But we have decades of research with lichen sclerosis on the vulva and using steroids. And we know that steroids are very safe as long as you use them as prescribed. And this is part of the education around lichen sclerosis, is that the physician or the care provider should show the patient exactly how much to apply. And we recommend using half a fingertip unit. So one fingertip unit is from the last crease on your finger to the edge. And we recommend using half of that, or kind of like a chickpea size amount. So you don't have to use it sparingly. Sometimes we'll have people where they put the steroid on with a Q-tip, and that's not what we want as well. And we show them exactly where to apply that in the office. So we do an educational pelvic exam with a mirror and show them exactly where the skin changes are, exactly where the inflammation is, and exactly where we want them to apply it. And that's a really important part of the treatment, is that type of education, because for many people, they don't know where the vulva is. They don't know where the vagina starts, and where the lichen sclerosis is. Many people will think that that's inside the vagina. So we really want to show them exactly where to apply it, which is usually around the clitoris, the labia minora on both sides, the vulvar vestibule, and the perineum and the perianal area, if that is where the lichen sclerosis is. So that's,
Sorry, I
yeah,
didn't mean
that's
to cut you.
the so that's the kind of the physical or the medical treatment part. I think I'll let, if you have any questions about that.
Do
Yeah.
they take it then? Because from what I understand, then there'll be kind of times in their life that maybe they would describe a flare, and then a time where that it almost calms down and they're not symptomatic. Is that pretty accurate, Melanie? Yeah. So
Mm.
are they using this topical every day then till death do they part, or only when they feel the symptoms?
So that's a great question and very important part of the education on the physician's part. So lichen sclerosis is a chronic, lifelong condition that does require long-term treatment. So our goal with the initial management, usually when people come to see us, they're very symptomatic. So our goal with treatment is to get those symptoms under control. And so we recommend, everyone has different regimens, and we use a regimen where we have people apply it daily for 1 month. And we would expect them to notice improvement within about 1 to 2 weeks. But we want them to continue it daily for a month. And then we have them taper down every second day for a month, and then down to twice a week. And this is what we call a maintenance treatment. This is what we want them to be on long term. We want them to use this even if they don't have symptoms. And the reason why is because we want to try to avoid flare-ups of symptoms. So we want to prevent that daily itch. We want to also prevent changes to the anatomy. So to prevent that for the flattening, that resorption, that covering of the clitoris, we really want to prevent that progression.
And I I could tell that before I cut you off there, I think that you were going to mention that another part of the treatment protocol is not just physical or medical, and that maybe I think that you're going to say that their part of it has to do with kind of the mental aspect or the emotional aspect. I'm curious to know what's included.
Yeah, absolutely. So a really important second component is the addressing the psychosexual or the emotional impact. And just even recognizing that someone is going to have all of those emotions that we talked about earlier on, so that first in our appointments, there's like a feeling of overwhelm and sadness or grief with that diagnosis, particularly when we talk about this being long term, and this is and there may be changes to the anatomy already. And there may be some anger, some frustration, some anxiety, some shame as well. There's a lot of vulva shame in our society. And so I think an important thing that a clinician can do is just allow the space for those emotions in that appointment, and just validate those, and say that they're expected, and just providing that space for listening to, how are you feeling with this diagnosis, and not just how are you feeling physically. So and giving that space. And in our clinic, we're really lucky because we have a multidisciplinary clinic. So we have a psychologist, and we also have a physiotherapist that we can have people have one-time appointments with them. I wish we could provide long-term care, but we can't. But we also have resources for therapists who are vulvar friendly or vulvar aware, and can help someone navigate all of those emotions around a diagnosis of a vulvar skin condition. We've connected with some lichen sclerosis support groups as well, and there are two in particular that we just love. There's Jacqueline at the Lost Labia Chronicles, and Kathy at the Lichen Sclerosis Support Network, who are both very strong evidence-based, which we love, patient advocates. And they have a lot of information about navigating those emotions on their blogs and their podcasts. They do group support. And I know in particular, Jacqueline is going to do some individual peer support starting in the fall. And that's something that we're hopefully going to connect with her on. And podcasts like these are really important, just to allow people to have those emotions and to sit with them, and just to not resist them, and allow them to process that. And we don't, in medicine, we're not great at that, but I'm hoping to change that.
No, it's all of these are steps in the right direction, and I will make sure that I list those support groups in the show notes so that people can reach out, because I think you're right. Just sometimes just listening to this at the beginning to hear, okay, I'm not the only one. Now, steps that make sense to me to address this. Um, I'm curious, a couple questions that come from the treatment. One, what are the downsides of not treating it? So what happens? I want to pick your brain a little bit about some of the alternative things that I've heard about. But first, I want to know, because some people right away will say, oh my gosh, this has not been true. I think I've had this 10 years. What does this mean that I haven't treated this? And I also am curious to know, what if someone decides that they don't want to treat it? What are some of the implications there?
Mhm. So, the goals with treatment are to improve quality of life. So not treating lichen sclerosis. If someone is symptomatic, because that itch is moderate to severe, it can be debilitating. So that's certainly not something we would advocate for, is not treating it. And commonly why people don't treat it is because of a steroid phobia or a steroid fear, which is something that we'll see when people go to a pharmacy and they're talking to the pharmacist about using this super potent steroid on the vulva. They'll get a lot of pushback, and so we tell patients to expect that from the pharmacy and to really trust us when we're talking to them about the treatment. With there's always a concern of cancer with lichen sclerosis, and when you look online, those two words go together quite frequently, and can be terrifying for someone navigating a diagnosis. And the risk of cancer is quite small. It is thought to be also related to untreated lichen sclerosis. So where someone has active inflamed skin is more likely to turn into to a vulvar cancer. So definitely treating that inflammation and getting the condition under control, we feel significantly decreases the risk of cancer. And then, we also advocate for regular exams as well. So someone who, like the situation you mentioned, where they've gone for 10 years without a diagnosis, which we've actually seen that. When they come to see us and we do an exam of the skin and we reassure them that we don't see a cancer, then, and we put them on treatment, then the risk of developing cancer in the future would go down significantly. So it's more related to the inflammation. Yeah.
So I can imagine that if left unaddressed or untreated, I mean, your discomfort or your quality of life might go downhill, more stress, which could obviously worsen that chain of events. But I have heard, and again, I actually haven't looked at the data myself. I'm curious to know, is there any data? Because I think some people just like to approach it differently first, right? And I have heard of people before saying, well, can I manage this with an anti-inflammatory diet? Can I manage this with essential oils? I've heard. And those are the two off the top of my head that I've heard. And I wonder, is there any data at all supporting anything that's not the steroid option so far?
Yeah, bottom line is no, there's not. And but the answer to some of those questions, particularly around diet, is we actually don't know. We don't know for sure. And I have had I can think of maybe 2 or 3 people where they very distinctly could relate their flare-ups to eating certain types of food. And so there may be some of those answers that are out there around particularly diet and environment that we just don't know. So that's not something we'd recommend. Essential oils we highly recommend staying away from. They can actually be extremely irritating and caustic to the skin. We recommend staying away from anything scented, particularly once the skin is inflamed. Yeah.
Good to know. So I think if I think about, again, the person listening, and we don't have a center like you do in Vancouver. So I picture some of the questions that some of the listeners, the local listeners, will say. First of all, can people outside of the Lower Mainland access your clinic in BC?
Absolutely. So even though we're based in Vancouver Coastal, we are a province-wide clinic, and we see referrals from throughout the province. We have a very long wait list. We're not able to accept people from other provinces, but yes, we do.
And roughly how long would people, so I imagine someone would need to see their family doctor and request a referral to the clinic?
Yes, we do need referrals from family doctors, nurse practitioners, or also midwives as well. And our wait list is about nine months, although myself and one of the other gynecologists, Dr. DeHaag, we triage all the referrals. So if there's any concern about a cancer or precancerous, then we expedite those for sure. But for our sort of what we consider non-urgent, recognizing that everyone is technically urgent, it is about nine months. And people can find out that information on our website. It's bcvulvarhealth.ca. We have our referral form there that your family doctor needs to fill out. And we also keep an updated list of all of the wait times for our clinic as well.
So if someone was listening to this and thinking like, oh my gosh, 9 months that I have to deal with this, I think some of the takeaways would be, one, just educate yourself, like whether it be through some of these support groups that you've mentioned, or you're listening to this podcast, but just kind of first just taking away some of this information. I think too, I'm hearing that take a look at your own vulva, because nobody else has the same vulva as you, and no one else will be able to monitor it quite as well as you will, so that you can be able to share that information with your care provider, and you will be able to start. I think we don't take enough on ourselves as the clients. I think sometimes we put too much onus on our healthcare providers. And I think that we need to be kind of checking up on our own body too. So kind of doing your own assessments, educating yourself. And then would you suggest, because again, I'm playing devil's advocate here, but I picture some clients who would say, oh, I don't want to talk to my doctor about this. Like, I don't think, some of them will be like, I can talk to my doctor about anything. Great. I'm just going to go bring this up to them. I feel very well supported. But if I'm playing that devil's advocate, I can picture that some people would say, oh gosh, do I have any other options? So I wonder, for those people, would it be, that you would recommend to someone, do your data collection on yourself and go to your doctor saying, I wonder if I have this, would you do an exam? What would you suggest for people that, let's say it's not an option to come to your clinic?
Mm-hmm. Yeah, and I would just start off actually by saying that at our center, we are not the only people that can deal with Lichens sclerosis. This is absolutely something that family doctors and community gynecologists can certainly navigate quite easily. We usually see people who are chronic and refractory. So we do spend quite a bit of time doing medical education, and our talks and our conferences are always very well attended. So there's so many family doctors who can manage this very, very well. Yeah, the answer to your question can be complicated, because what you're assuming is that someone has Lichens sclerosis. But what's important to keep in mind is that vulvar cancer and precancerous changes on the vulva can actually present with itch as well. So I would certainly advocate for doing self-exams and for writing down and keeping track of your symptoms, and kind of keeping that list. But I would definitely advocate for early visit to a physician for an exam. And I would, a big kind of goal of mine is to really just normalize conversations about the vulva and vagina. So I would be really curious, why does someone hesitate to see a medical professional about their vulva? It's just a part of the body that has that medical professionals should be really comfortable examining as any other parts of the body. But you're right, that education and advocacy for yourself is really important. And I would kind of see it as you working towards being a team with your healthcare provider and partnering with them to manage your conditions, get a diagnosis, and get effective treatment.
That's great. And so then, do you suggest then that if someone, is working with their family doctor and they feel quite well supported, would this be something that they should have regular checkups? Oh, and then my second part of the question is, or do you think that normally would would this person be managed by a gynecologist? And is that something that people should advocate for? I'm curious to know your thoughts on that.
Yeah, so that would be very individualized depending on the family doctor. There are many family physicians, both male and female, who are comfortable managing um, skin conditions. They're comfortable making the diagnosis, and they don't necessarily need a referral to a gynecologist. And then there are some physicians where they're not so comfortable managing it, and they prefer to send in that referral. We'll also see people sometimes for one-time consults, particularly people who live outside the Lower Mainland, and then once their condition is controlled, they'll go back to their primary care provider. And when the condition is well controlled, we recommend annual examinations. And that's just to document, is the condition progressing? Is it really well controlled? How often are you using your steroid? Are you using the right amount? Are you putting it in the right spot? Um, and to just check in and see how things are going. So we recommend that on an annual basis.
Okay. And then obviously that's kind of for kind of physical or medical management. And then if I tie into the other piece that you explained so beautifully too, is that acknowledging that there are individual psychosocial aspects. And so honoring that and acknowledging that maybe talking to a mental health professional, or what are my sleep habits? What are my stress habits? Am I eating healthy? Because this isn't just it doesn't need to just be managed by medication, but kind of thinking of that multifactorial approach, and that no two people, I always picture a puzzle and everybody's made up of a puzzle, and we all have different pieces, and some pieces for some people are bigger than others. And so figuring out your own puzzle and advocating for what pieces need to be addressed, but there's never just one piece, right?
Absolutely. Yeah. And then, the other piece we haven't talked about yet, maybe you could add in, is the role of the physiotherapist as well.
Well, absolutely. And I think that's exactly what I kind of had my last little question to ask you, is any advice for physios from your point of view? Because I mean, I think if I come full circle to how I started this and this podcast, and just that this isn't our scope of practice, the skin conditions per se, and as far as diagnosing or treating, but they're always a piece of the puzzle. And really kind of thinking of, what's this person coming in for, and what are all the things that they're mentioning? And generally their history and their story tells you so much, doesn't it? And
Oh.
I find one of my biggest roles is just to help people understand their body, understand their anatomy, understand what things to look for, and then understand what questions to ask. Because I think sometimes we need to, like I said, take a bit of an active role in our own healthcare. And
Mhm.
as physios, I think, I dislike the term pelvic floor physio, because I think it makes us look like we just look at the pelvic floor. But, if someone comes in with shoulder pain, I'm always going to ask too, like, when did it start, and what kinds of things make it irritated, and what have you done so far, and what movements are sore. And I wouldn't just look at one muscle in the shoulder. I would look at the whole person and their goals, and how they sleep at night, and what their beliefs are, and what they know. And the pelvic floor is just a muscle, and there's everything else that contributes to that. It's a piece of the puzzle, and what else is contributing to that puzzle. So I wonder if you have any other thoughts too on, there are a lot of physios that listen to this, and I wonder if you have anything else that I didn't say that you'd like for them to take away from this.
Yeah, no, I think you've covered it really well. I think one thing I do kind of talk about to any healthcare provider is just to be really mindful of the language that they're using, and this is something our group has discussed, and we decide on kind of the best type of language to use. But specifically related to this, I would stay away from words like normal, and really just describing anything that you see, like we use the words flattening rather than disappearing, resorption rather than disappearing, using words like inflammation rather than healthy and normal, and because those can just be a bit triggering for some people. But you're exactly right. That pelvic floor muscle is very intimately related to the vulva and to all other parts of the body. And I find that physiotherapy can just be so helpful with that education and giving people that information about their own body and how it works and how it's all connected, and kind of specifically related to the pelvic floor activity that we see when people are experiencing an active Lichens sclerosis, and they're still trying to have insertional sex, that they can get that kind of ramping up of that activity that can require physio to help to regain control of the pelvic floor.
Mm-hmm.
Yeah.
And I think the only other takeaway that that we touched on, but maybe didn't really label, is just the importance of knowing your anatomy and the proper terminology, right? Because I think that everything down there just becomes the vagina. But then sometimes you don't know how to ask your questions, right? If you can't describe where you're feeling something, I notice that all the time. And then it creates even more embarrassment. So I can see why people don't want to maybe bring that up, maybe especially if they have a male doctor, that, oh, how do I don't even know where to describe it to him. And, so I think that too, just even as people listening to that have children, the importance of teaching them their proper body parts and what they're called, so that when something doesn't feel right, you're able to point out where that is. Because this can be it's very much like down there feels weird, but that doesn't tell people much, does it?
Absolutely. Yes. I think being able to differentiate between the vulva and the vagina is very important.
Mhm.
And that there are many journalists out there who could who could learn that as well.
Yes,
Is
yes,
they'll say vagina when they
yes,
actually mean the vulva. But
yes,
yeah, I think that's just a great starting place for everyone.
yes.
Yeah.
Well, unless you have anything else, I really want to say thank you so much for your time, because I know that I can imagine your job is very busy and it's summer. So there's so many fun things to do. But I know that I will be sharing this episode with so many people. And I appreciate, I can see that there's a lot of collaboration going on now, because there's so many different centers like your own, or different platforms that think, you know what, I can see that this area of practice really needs some attention. Now, how do we let people know about this, right?
hmm I absolutely agree, and yeah, I'm so grateful you reached out. I think our missions are very aligned, so it's been lovely working with you.
Well, thank you so much.